Manoj is the head of nutrition services at Chaitanya Hospital in Toronto.
Good afternoon. Thanks, Manoj, for giving me this opportunity. My topic is, this talk is titled DME Management in the Post-ETDRS Era, the Role of OCT. We all know that macular edema is a common cause of vision loss in diabetic patients, and the ETDRS study has established that laser is an effective way to treat diabetic macular edema, in that it reduces moderate vision loss by 50%. But then we also know that a significant percentage of patients continue to lose vision or had persistent thickening at 36 months of follow-up in that study. And therefore we understood that laser is just not enough to treat these patients. The advent of OCT has actually revolutionized our understanding of diabetic macular edema. We use OCT not only for diagnosis, but also we try to classify CSME based on OCT findings. And this is and also management of CSME has undergone a great change with the advent of OCT. Now these are some of the questions that I'm going to try and answer in this talk of mine here. The first question is, can OCT actually replace the traditional diagnosis of CSM? Now that we are doing a lot of OCTs, should we do away with clinical examination? The ETDRS criteria, we all are aware of this, is based on three variables: the presence, the location, and the area of retinal thickening. One thing which the ETDRS study did not take into consideration was the axial thickness. And now we know that from various studies that axial thickness is a better correlation to visual acuity. And the other thing that we need to keep in mind is that ETDRS, the diagnosis of CSME is based on stereophotography. In clinical practice, what we do is fundus biomicroscopy, which is definitely both the contact and non-contact are inferior to stereophotography. Now we also use these terms focal and diffuse CSMEs quite loosely. Focal CSMEs refer to leaky microaneurysms, and diffuse CSME refers to leaky capillaries. And we also believe that focal DMEs have better prognosis and diffuse DMEs have worse prognosis. Now what is focal and what is diffuse is not really well defined. It's quite subjective and quite arbitrary. The ETDRS readers and the global DRP group did not use this term in the primary diagnosis of diabetic macular edema. Actually, this term was coined by the ETDRS. It was based on an FFA grading, and it was meant to help us to treat this patient. It was a treatment guide. So following this, many people have described diffuse CSME. They have used different criteria. Some people have used CME, the number of microaneurysms maybe have been used. The area has been used as a criteria. And again, people have also used hybrid definition. Have used both clinical FFA and OCT based criteria to define what is diffuse CSMEs. So the point is, how many of us actually do an FA before laser these days, especially with regard to diabetic macular edema? And UK audit found only 19% of the medical retinal practitioners using an FA before treating diabetic macular edema. The DRCR network also found that only 50% actually used an FA. So we are now moving away from FA, and therefore we need to move away from these terms, focal and diffuse diabetic macular edema. And therefore, because OCT has become an integral part of our practice, we may have to define these edemas in a different way. Now OCT, as we all know, it helps us not only to quantify the area of thickening, the extent of thickening, it also helps us to identify the patterns of macular thickness, vitreoretinal interface changes, and photoreceptor abnormalities. We have all these wonderful maps which tell us very clearly, which shows very clearly the extent of involvement, the density of thickness. We also have subtraction maps which tell us the extent of improvement or worsening over a period of time. And this has already been covered. Various patterns of DME has been described: spongiform thickening, cystoid thickening, submacular detachments, and vitreoretinal interface changes. Now, is there an absolute CFT value? If you look at all the recently conducted studies, you see the values have been different. A recent Cochrane review looked at this, and they suggested that anything between 200 and 300 microns, anything above it, can be considered significance. So that means we don't have an absolute CFT value as of now, beyond which we can say that this is a significant thickening. Now again, there is this new classification of new term that is used, tomographic DME or subclinical CSMEs. The first described by Brown et al. Is basically an OCT-based diagnosis. These patients did not have clinically significant macular edema. Browning et al. Followed up these patients and realized that nearly one-third of these patients progressed to CSME over a period of 14 months. The baseline CFT in these patients were 238 microns. Like in this patient here, this is at baseline here. The patient we thought did not have clinically significant macular edema, but you can see that there is a significant extrafoveal thickening. And over 6 months, he had patient progress to clinically significant macular edema. And various studies have also shown that there is a concurrence between clinical examination and OCT, especially for those between less than 200 microns and for those more than 300 microns. So between 200 to 300 micron thickness, there is actually no agreement between clinical examination and OCT. Again, studies have also shown that there is a correlation of intraretinal abnormalities on OCT and FFA. We know that early CMEs are better picked up on OCTs than on FA, and again, submacular detachments which are easily missed on FA and can be picked up on OCT alone. So therefore, OCT is definitely more sensitive in detection of retinal thickening and diagnosing clinically relevant macular edema. But however, the Cochrane review also found that there is no significant correlation between stereophotography and biomicroscopy with OCT findings. Also, they found that there's 11% of patients had false positivity. That means if we had used OCT as a criteria to diagnose CSME, we would have overtreated them. So again, this is a slide which all the recently conducted trials in diabetic macular edema. If you look at this, all these studies have used OCT as a criteria, but along with the clinical criteria. So none of these studies have used OCT alone as a criteria to diagnose clinically significant, diabetic macular edema. And therefore, we have to use OCT, and in terms of diagnosis, we have to use OCT along with the clinical examination. The next question is spectral domain OCT better than time domain OCTs? Now the answer we do not know because we do not have comparative studies, because all the trials have looked at time domain machines. But then we know that there are significant differences between the spectral domain and the time domain OCTs. The resolution is much better with the spectral domain OCTs. Intrasessional variability is much less. Artifacts are much less. The study of ISOS and ELM are best with spectral domain machines. And the other thing that we need to keep in mind is the retinal thickness is going to be different when you compare these two modalities. In spectral domain, it's going to be around 30 to 55 microns more than what you would measure on the time domain, because we measure between the ILM and RP and not between the ILM and ISOS. The next question is OCT a better correlate to visual acuity? The answer is yes, because we know that clinical CSME does not correlate with vision, especially the non-center involved CSMEs. We also know that processes like vitreomacular interface abnormalities, cystoid macular edemas, submacular detachments, which can have poor vision, are easily missed on a clinical examination. Now, there are a lot of studies which have definitely shown that there is a correlation between central foveal thickness and vision. The amount of axial retinal thickening, more than any other measured variable, has been shown to correlate with visual acuity in diabetic macular edema, and this has clearly been established by the DRCR network. If you look at this table, you can see that as the central foveal thickness increases, the percentage of patients having poor vision also increases. But then the DRCR network also reported that there could be a paradoxical response in 17 to 26% of patients. So CFT alone should not be used as a criteria. We have to keep this in mind that there could be a paradoxical response in certain groups of people. Again, the pattern of macular edema and vision, though controversial, though conflicting reports have been there, patients with CMA and subretinal fluid may be associated with poor visual acuity. The next question is OCT a better guide to treatment of CSME? Now, the management of DME, as I said, has undergone a sea change. We now talk about early diagnosis, we are talking of early treatment. We broadly divide DMEs into tractional and non-tractional DMEs. The role of lasers is now threatened. We've used less laser. We in fact use milder lasers. There are a lot of micropulse lasers and all that. We use more intravitreal pharmacological agents. We talk about combination therapy these days, and we also have these terms, refractory diabetic macular edema, which for patients who have undergone laser and who have persistent macular edema. And we are all aware of the various morphological patterns on OCT. Dr. Preeti had already shown us this, and various classifications have come about. And these morphological patterns may help us, shown that there's some kind of correlation with retinal sensitivity and vision. And people have also gone ahead and classified DME with CMEs into mild, moderate, and severe. But then I like this classification here because it not just involves the retinal thickness, it also looks at various other things, retinal morphology, the topography, macular traction, and photoreceptor status when you look at diabetic macular edema. In this classification, retinal thickness is divided into three groups: no macular edema, subclinical macular edema, and established macular edema. Based on the OCT and biomicroscopy findings, subclinical macular edema is defined here, central foveal thickness more than 2 standard is thicker from the normal. Retinal morphology, non-cystoid and cystoid. Cystoid are divided into mild, moderate and severe based on the size of the cyst. Macular traction, no traction, questionable traction and definite traction based on the vitreomacular interface changes. Retinal outer layer integrity intact or disrupted. So some of these morphological changes may be associated with poor prognosis, like the conflicting presence of cystoid macular edema and SMD can be associated with poor visual prognosis. Again, we know that vitreomacular abnormalities and outer layer abnormalities have been associated with poor vision. So in our practice, this is our experience, we divide DMEs broadly into tractional and non-tractional DMEs. We know that in tractional DMEs, it's well established that vitreoretinal surgery is the treatment of choice. But in non-tractional DMEs, we wanted to see how an OCT-based classification may be useful in terms of management. This is a study which we did at our center. We had 276 eyes as part of this study. It was basically a retrospective analysis. Eyes which had completed 1 year of follow-up, we excluded BMT and patients who underwent PRP and who had fairly good 1 year follow-up. Our protocol, basically we did a good systemic examination, a thorough ocular examination baseline. We divided patients into 3 groups: spongiform edema, cystoid macular edema and submacular detachment. All these patients received combination therapy, most of them. The spongy edema group received either laser or combination therapy with anti-VEGF. The cystoid macular edema group were treated with combination therapy with anti-VEGF or IVT. Submacular detachment, patient received either combination therapy with anti-VEGF or Ozurdex. Focal laser was done 2 to 4 weeks after intravitreal therapy. Patients are followed up at monthly visits and retreatment was using the same protocol. The mean age was 53 years and the duration of diabetes mean was 15 years. At baseline, almost 50% of the patients had cystoid macular edema. If you look at these 3 groups, we found that SPA1C values were fairly similar in these 3 groups. We however found an increased incidence of nephropathy in the group with SMD, which we found to be statistically significant. Out of the 95 eyes with spongy edema, 54 eyes were treated with laser and 41 eyes had undergone laser with Avastin. The final visual acuity, though seemed to be different, was not statistically significant. In terms of macular thickness, again, there is no significant difference between the 2 groups. These are examples of patients who received the focal laser. The average number of focal lasers over 1 year was 2 sessions, and these patients had a fairly normal fovea at the end of 1 year. Some patients received combination therapy. Most of these eyes had spongiform edema involving the center or had hard exudates along with the edema process. Out of the 137 eyes with cystoid macular edema, 88 eyes had received laser with Avastin and 14 eyes were treated with laser with IVT. In terms of visual outcome, the anti-VEGF eyes did well. It was mainly because many of the eyes in the IVT group also had developed cataract. In terms of macular thickness, though there was a difference, it was not statistically significant. This is a patient at baseline CME who received multiple injections of Avastin and laser to maintain a relatively dry fovea at 1 year. And this is again a patient with baseline cystoid macular edema who received 2 injections of IVT and laser to maintain a relatively dry fovea at 1 year. The submacular detachment eyes, out of 44 eyes, 31 eyes received laser with Avastin and 13 eyes received laser with Ozurdex. We avoided IVT because we found, in an earlier pilot study, we found that a significant percentage of these patients had nephropathy, and we wanted to avoid IVT and Ozurdex because it has less incidence of glaucoma. We thought it would be a better option. And if you look at the final visual acuity, it is not very different between the 2 groups. Macular thickness, again, it is not significantly different between the 2 groups. And these are examples of patients with submacular detachment who received Avastin and laser. And again, submacular detachment at baseline, patients received Ozurdex. Patients required 2 injections of Ozurdex over 1 year, along with laser sessions. Again, we also looked at eyes which had macular ischemia. Out of the 80 eyes which we had used an FA initially, we realized that 64% of these patients had central cysts. And some of these patients, again, during follow-up, many of these patients had persistent central cysts during follow-up. They would have had submacular detachment, but ended up with persistent central cysts. And later we found that many of these patients had macular ischemia. And looking at the treatment frequency, the CME eyes received the maximum number of intravitreal injections. Combination therapy, eyes received less laser compared to monotherapy, and that is well known. So broadly, no significant systemic or ocular complications were seen except for glaucoma, which is seen in 34% of patients who received IVTA. But what the study has taught us is that OCT differentiation may be useful in the management of non-tractional diabetic macular edema. Certain OCT patterns may respond better to treatment, and CMEIs, laser with anti-VEGF, may be better than IVTA, and then SMDIs, both anti-VEGF combination therapy with anti-VEGF and also are good enough. Spongiedema eyes still do well with laser. Certain OCT features may help us to understand associated systemic pathology, like in a person with SMD, you should suspect like nephropathy. And certain OCT features may help us to prognosticate. And during follow-up, if we see a patient central persistence cyst, you should probably think of macular ischemia. The next question is the final question that I would like to answer: is OCT a better tool to follow up of patients? There is no denying this. It is definitely a better tool because in comparative clinical examination, it's a very sensitive tool to detect retinal thickness change. Look at this table here, all the recently conducted trials. Definitely OCT has been a criteria that has been used to retreat these patients. So in follow-up, definitely OCT has a major role to play. So to conclude, OCT has changed our management of DME in the post-ETDRS era. We use OCT now to diagnose early disease before it becomes obvious on biomicroscopy. We can call them a subclinical disease, but whether we need to treat them or not, we are not sure at this point of time. OCT also helps to differentiate different morphological forms of the disease, which may help us to facilitate decisions on treatment protocols. We now talk about customized treatment for diabetic macular edema. OCT also helps us to correlate with visual loss. The central foveal thickness is one of the most important criteria that we need to use. And being a non-invasive tool, it's an excellent tool in monitoring disease progress and treatment outcomes. Thank you.